Good morning, everyone. Today is a Drew Wilsey Memorial Lecture, and I have a few words about Drew Wilsey in case there are maybe a handful of you who have known Drew Wilsey during his lifetime. The others probably are wondering who Drew Wilsey is. He came to Children's in '83 and served the hospital as the education and transport coordinator for respiratory care services. He was a respiratory therapist here. He was a very much liked and well-respected member of the respiratory care community. He was actively involved in the clinical, educational, research, and political aspects of the profession. He was a leader who motivated and inspired students and staff alike. He passed away in 1998. To honor and recognize the significant contributions of Drew Wilsey, an annual Drew Wilsey Lectureship was established in 1998. The Department of Pediatrics permitted this lecture to be part of the Pediatric Grand Rounds. I'm very grateful for that. There's also an annual Drew Wilsey Award of Excellence in Respiratory Care that's given to a respiratory therapist that is selected by their peers. This award is given to a respiratory care staff member who is chosen by their peers in the department for their excellence in patient care, teaching, research, and advancement of respiratory care profession, exemplifying all that Drew Wilsey stood for. When I say that he was an excellent educator, I'm not just saying he was an excellent educator in respiratory care. He was the best educator that I've had the experience of learning from. He taught me the innards of mechanical ventilation. And the way he made me learn was put out a big sheet in the conference room, moved all the tables, took the ventilator apart, part by part. And my job was to put them back exactly in the correct sequence and make sure it works. And when he taught you, he would give you clinical examples of how to set up a ventilator. And he would give you a list and he'll teach you the list. And he'll ask you, okay, go ahead and do it. The first time I did it, I missed 2 steps and I was on step 12, but I called it step 10. And I realized I had missed 2 steps. I said, hey, Drew, I missed 2 steps, right? He said, yeah. Which ones? I'm not telling you, go start from 1. That's the way he taught. And any respiratory therapist that was taught by him leaving orientation, one could be 100% certain that that person knew how to do things around in the unit. There was no question about it. Well, it's been 25 years. I miss him. And Jordan, our current respiratory care director, is going to announce the results of the Drew Wilsey Award.
Good morning, everyone. My name is Jordan Calavoto. I'm the respiratory director. I've been in my role about a year and a half now. I've been with UPMC for about 12 years. I'm just going to highlight the department real quick and give out the award. So the respiratory department has gone through a lot of changes in the past few years throughout leadership changes, the pandemic, staffing difficulties. The department has shown great resiliency through adversity and countless problematic situations. One thing that has not changed is their dedication to superior patient care. The ERTs often go unrecognized, especially when things are running smoothly, but it's certainly noticed in a crisis when they are not there. The respiratory staff is often asked to be in multiple places at one time. They're responsible for covering almost every area of the hospital. They're actively involved in all the critical care units, all of the acute care units, codes, traumas, intubations, transports, trach patients, the list goes on. It's a daily occurrence for the staff to tell me, like, I'm all excited to, like, hey, what are you guys going to do about this? They always tell me, hey, we'll make it work. So the winner of the Drew Wilsey Award embodies all the attributes listed that Sheikh talked about. She is kind, compassionate, and a great mentor, teacher. She displays all of the UPMC values on a daily basis. This year's winner of the Drew Wilsey Award is Jill Ader. This is for excellence in patient care, teaching, research, and advancement of respiratory care. So congratulations, Jill.
Welcome to Grand Rounds this morning. I think really this just epitomizes today that we are a team and that we cannot practice medicine without all of our efforts together. And the lecture today is going to talk about efforts that we need to do as a community as well to help. All we need is the air we breathe. So I am pleased to introduce Dr. Franziska Rosser today as our Grand Round speaker. I'm Noelle Spears. I'm the Vice Chair for Education for the Department of Pediatrics. And Dr. Franziska Rosser is a pediatric pulmonologist here at UPMC Children's Hospital of Pittsburgh. She's an assistant professor in the Division of Pulmonology. She specializes in the care of children with respiratory disorders and is a former clinical and translational science KL2 scholar. She's received funding from the American Thoracic Society to conduct a pilot clinical trial to evaluate adding air quality index to routine child asthma care. And she's currently the PI of a KO8 evaluating the association of outdoor air pollution on airway omics in children with asthma. She's a member of the American Thoracic Society Environmental Health Policy Committee and has provided testimony to the EPA regarding the current ozone and PM air quality standards. She's a firm believer that clean air is a basic human right and should not be dictated by where a person lives or how much money they have. So with no further ado, Dr. Franziska Rosser.
So I wanted to say thank you to Noelle for the kind invitation to speak. This is truly my honor to be here today to speak to everyone. I want to start with a couple disclosures that anything that I'm going to express and the views that I'm going to say are my own. They don't represent my current or former employer. They don't represent any of my funders. I'm not going to talk about clinical care guidelines today. And I am going to maybe mention a couple air monitoring companies. And just because I mentioned something does not mean that I am providing an endorsement. So I want to start off with just a roadmap of where we're going to go over the next 50 minutes or so. And I really had a hard time putting together this talk because there's so much that I want to talk about. And for those of you that know me, know that I could talk for hours about this. But if you decide to go to sleep right now, if it's a snoozer now, I'm going to tell you where I'm going to end up. And that's that clean air is good and dirty air is bad. And for the rest of the talk, I'm going to try to convince you of that by telling you a little bit about air pollution, a little bit how kids are different. And then I'm going to finish up by talking about the air quality index, because the more that I have looked into the air quality index, the more I realize I don't understand about it. And the more physicians and even environmental scientists I've talked to, the more I realize like, wow, there's a lot going on here for us to know. So I'm going to start off with the lungs. And I'm going to smile as I say this. I dare say it's the most beautiful organ in the body. And the lungs accomplish respiration, one of its primary functions, so getting the oxygen in and your carbon dioxide out over this very large and impressive alveolar surface area, about 140 meters squared in adults, which is 1,500 square feet. That's a decent house, right? A lot of surface area. And in adults, we move about 8,000 to 12,000 liters of air a day. So this is a lot of air over a lot of surface area. And I find it fascinating, which is the word I'm going to use for this polite audience, that there's companies that market air purifiers, when scientifically speaking, there's no such thing as pure air. Our atmosphere is about 78% nitrogen, 21% oxygen, and has a whole bunch of other stuff in it, viruses, bacteria, dust particles. So we see a lot of air over a lot of space and a lot of that air during the day. So what's in that air absolutely matters. And when I think about our atmosphere, there's probably been some big changes within evolution for what our atmosphere is seeing. So there probably was a big change when mankind learned to harness fire and when mankind learned to use agriculture. But by far, most of the pollution that we see today is coming from the Industrial Revolution, from our fossil fuel, both the extraction, the generation of energy from it, and then also its combustion. And I got this picture from a tobacco cessation ad, but the analogies to air pollution are there. So just like tobacco smoke, we know that tobacco smoke causes premature death, cancer, lung disease, heart disease. Fossil fuels do this too. Fossil fuels, particle pollution causes premature death, massive premature death globally, causes lung disease, heart disease. And just like we've had good policies that markedly reduce tobacco usage, we've had policies that have reduced fossil fuel usage and our reliance on fossil fuels. And this is an area we need to do more. We need better policies. So in preparing this talk, I read this article from Dr. Goldsmith, and this article was placed in 1968. So this was even before I was born. And it's entitled Air Pollution Epidemiology, a Wicked Problem, an Informational Maze, and a Professional Responsibility. And he says in here, epidemiology is literally translated as the science of that which is upon the people. And there is nothing more universally upon the people than the blanket of the Earth's atmosphere, which immediately surrounds them. What man does to this blanket and what it does to him are questions that cannot but be of massive relevance and greatly deserving of planning, management, and systematic study. And this was true 5 decades ago, and it's very true today. And I show this picture because I wanted to hearken the wicked problem that is air pollution. And wicked problems are complex, and there's lots of things going in, and they're difficult to solve. I would argue it's not quite as that wicked because, right, our reducing fossil fuel reliance is definitely going to improve our air quality, but it's a wicked problem. And then I thought about, you know what, but air pollution kind of is like a tornado, all right? And then there's ways it's not, and I'm going to share both with you. So ways that it's like a tornado can have short-term effects and long-term effects, and air pollution does that too. It also can vary within space and time, and air pollution varies within space and time. In ways that it's not like a tornado is that we generally can see tornadoes, and we generally cannot see air pollution. I can't see it as a clinician, and I can't see it as a patient. It's really hard to identify when air pollution is causing health harms. The other thing is a tornado generally, where it's formed, it kind of stays, right? It moves around. Air pollution isn't like that. So we can have things such as ozone, where the precursor agents are coming from our neighbors like West Virginia, Ohio, and then suddenly we have air pollution problems here in Pennsylvania because of it. So this is just a picture showing some places of where air pollution comes from. So you have mobile and non-mobile sources. I hope you leave today knowing that roadways are just nidus's for air pollution, right? It's that place where you have fossil fuel combustion, but you also have non-road sources. So thinking about aircraft, thinking about shipping, and then you have point sources like industry, and then also non-point like forest fires or chimney. Anytime we burn anything, we're creating air pollution. This is a busy slide. We're not going to go through all of it. I just want to point out that the atmosphere is not a sterile environment. There are chemical reactions that are going on all the time in our atmosphere. And for ozone, ozone is not emitted. Ozone is formed in the presence of nitrogen oxides and volatile organic compounds in the presence of heat and sunlight. So again, just because something isn't emitted doesn't mean that you're not having these formations that undergo in the atmosphere. And this leads me to particle pollution. And so this is a figure that I created. What I'm trying to show you here is the diameter of a human hair and the size of particle pollution. What I get wrong in this picture is that I've drawn PM10 as like just this homogeneous sphere, and PM2.5 is all looking the same. And that's not particle pollution. Particle pollution can be solid, but it can also be liquid droplets. And you can see some aeroallergens, so think about like pollen, dust mite poop, cockroach poop. Little bits of that can actually hook on to these small particles, and that can allow them to travel further down into the lungs. There's also chemicals that can attach, like polyaromatic hydrocarbons, volatile organic compounds. They're not homogeneous. And what makes particle pollution so dangerous for respiratory health is that the larger particles are going to get filtered up in our upper airways, right? So our nose, the trachea. These smaller particles, PM 2.5 are fine, are so tiny they can make it all the way down into the alveolar spaces. And those ultrafine particles, which aren't monitored by the EPA yet, they can go wherever they want. They're so tiny, in fact, they've been found to translocate that alveolar capillary barrier and have been found in other organ systems in the body, including brain biopsies. So this is a figure of Pennsylvania, and what I want to highlight about this is that air pollution varies in space and time. And so this is for PM 2.5 in Pennsylvania, and you can see our region, which I highlighted, Allegheny County, we're not good. We're one of the higher regions, same thing with Philadelphia. But even when we look at, okay, I told you that PM 2.5 is not all the same. When I look at, well, what's in those PM 2.5 particles? About 43% of it is organic material, about 17% sulfate, 12% black carbon, 10% nitrate. And more studies are coming out showing that these constituent components matter with regards to the health impacts, even in pediatrics. I'm going to quickly go through this, but this is just to show you the spatial distribution of these individual constituent components. And again, this is very different from the slide I just showed you. So you can see with nitrate is much higher in Philadelphia. With us having nitrate, PM 2.5 is lower, although here in our region, we have difficulties with black carbon and then also sulfate. We know this in pediatrics. We know that kids are not little adults, but this is so true with air pollution, and we can't use adult data to extrapolate what are the harms on children because children are uniquely different, and I'm going to talk to you about that. I do want to go over some basic air pollution 101, right? So the poison is the dose. So your dose of any air pollution depends on the concentration of it, right? If you're in an environment with more air pollution, that's more of a dose. If you're in an environment longer, so the duration that you're in it, more of the dose. The more you breathe, so the more air you're taking in, the higher your air pollution dose. So if I'm sitting outside, I'm going to take in less air pollution than if I'm exercising and really increasing my minute volume ventilation. So kids are uniquely susceptible for a lot of reasons. They have increased mouth breathing. So all of this upper airway nasal filtration is bypassed. So they're getting more of a dose by bypassing that. They also have higher ventilation rates per body weight compared to adults. So in the same environment, they're going to breathe more air per their body weight than we are. Kids spend more time outdoors. And anybody that's walked with a kid knows that their activity level, they're skipping, like, come on, let's go. They're moving a lot more. The other thing is that kids are developing. Their respiratory systems are developing, their metabolizing systems are developing, and their immune systems are developing. So this is a figure showing on the left-hand side human lung development. And there's 5 stages of it, and it starts in utero, and 4 of them kind of complete in utero. And that last phase, alveolarization, starts at the end of the 3rd trimester, and we actually don't know when it completes. There's some evidence that it completes in adolescence, but we do know that the bulk of alveolarization occurs around 2 to 3 years of age. So if you can imagine, if you have an insult at this particular time in your life, it can have long-lasting consequences on your respiratory health. Not only are kids' lungs developing, they're also still growing. So FEV1 is a marker for your airways. They grow throughout childhood. FVC is more of a marker of your alveolar spaces. That also grows throughout adulthood or throughout childhood. It plateaus in early adulthood, and then it's downhill from after that. So again, when you have insults that arrest this growth process, it can have long-lasting consequences. And indeed, lung function reached in early adulthood can have implications for adult onset disease. And so the figure on the right-hand side is showing adults with either normal in blue or low lung function in early adulthood, and the prevalence of other diseases such as respiratory diseases, cardiovascular, and metabolic. And you can see that they're increased. So the whole idea, right, you've heard the adage, what happens in Vegas stays in Vegas. Applying that to children's lungs, what happens in childhood can absolutely not stay in childhood and have implications for their health as adults. So we know that children are more susceptible, and I can tell you that persons with respiratory disease are more susceptible to air pollution. But susceptibility does not exist in isolation. It's on a spectrum. And the things that can modify someone's susceptibility include genetics, so things like GSTM1. And that's in persons that have reduced ability for antioxidants. Epigenetics, such as FOXP3. Physical activity can modify the effects of air pollution, with most studies showing that physical activity is beneficial. Obesity, your nutritional status, co-exposures like tobacco smoke exposure can all have impacts, as well as socioeconomic status. I would love to spend an entire day talking to you about this slide, but I can't. I'm just going to tell you that in healthy kids, the effects of air pollution, there's been associations with premature birth and low birth weight, which is also a risk factor for childhood asthma and risk factors for adult onset respiratory disease, decreased lung function, increased allergic sensitization, increased respiratory tract infections, including bacterial and viral, and an increased risk of childhood onset asthma. And I'm going to use just the next couple of slides to kind of highlight some of these points. So this was a classic study from 2004 that looked at the percentage of FEV1 below 80%. So they used this as a marker of normalcy. And then they looked at nitrogen dioxide and PM2.5. And what they found was that as particle pollution and nitrogen dioxide increased, you had decreased lung function. They did a companion follow-up to this in 2015. So these are 3 different cohorts of children recruited over different times. And as a result of good policy, there was reductions in air pollution over this time period. And what they found was if you reduced air pollution, if you reduced PM2.5 and NO2, you had increases in lung function. And epidemiological studies cannot prove causation. That's one of the things, you always get worried about. But you have 2 studies now, one that shows that increased air pollution decreases lung function. And now you have an epi study that shows decreased air pollution increases lung function. And in my mind, that is compelling evidence of causation. These are older studies, a couple decades old, by Dr. Andrew Saxon and David Diaz-Sanchez, but I just love them, so I want to share them. What they looked at was the effects of air pollution and antigens, right? So this is things like pollen. And they found that they could induce neosensitization. So they took this glycoprotein, keyhole limpet hemocyanin, I'm going to call it KLH, and they put it in people's noses. And they found, okay, there's no IgE response. But when they put it along with diesel exhaust exposure, boom, IgE response. So they suddenly induced neosensitization. They then followed this up. They looked at putting in ragweed in persons who are sensitized to ragweed. And they found, yeah, okay, the specific IgE levels to ragweed increased, right? We would expect that. When they added diesel exhaust particle, you had 16 times the effect. And what this shows is that air pollution, although people are not allergic to it, it can promote a T2 type inflammatory response and acts as an adjuvant for allergic responses. I also want to point this out. This was an article a couple of years ago looking at short term, so PM2.5 and the association between lower respiratory tract infections in kids, any cause. And exactly as you would predict, air pollution is associated with respiratory tract infections. It's interesting, if you look over to those diagnosed with RSV, you can see that there's lag times. So it was, if you had elevated PM2.5, it was 2 to 3 weeks later that you actually saw the RSV infection. So the idea being, does the exposure to the air pollution increase your inflammatory response or change your inflammatory response or make you more susceptible to more severe disease? But I point this out because, again, I'm very good at looking at my patients and saying, yes, you have a virus, that's the cause of your bronchiolitis, but I cannot look at my patients and say, ugh, I think air pollution is in this mix and worsening what I'm seeing here. Almost 179 million. This is an incredibly big number This is the number of cases of new onset childhood asthma in 1 year, 2010, attributable to nitrogen dioxide. 1 year, new cases of asthma. And I just bring this up to say, when we talk about the costs of healthcare, is there a role for us talking about air pollution as a way to lower healthcare costs? All right, what are the respiratory effects in children with asthma? Again, I could spend a long time on this slide. What we see are increased asthma exacerbations, increased asthma symptoms, decreased lung function, and we certainly don't have enough data at this point to recommend anything different than asthma guidelines. But the studies are conflicting about whether inhaled corticosteroids, the mainstay of asthma therapy, protect against air pollution-induced harms. This is a paper from a couple years ago, and it's not novel in looking at proximity to a major roadway in asthma outcomes. It was novel by actually looking at school proximity as well. But I wanted to highlight, because I want people to understand that living near a roadway is associated with higher exposure to nitrogen dioxide, particle pollution, ultrafine particle pollution. And I say that because I'm curious driving around Allegheny County looking at all the new homes that are being built directly beside highways. And I wonder, is this an area where we could use better policy to help protect human health? And what they found was that for every 100 meters farther away, again, decreased asthma symptoms, decreased healthcare utilization, and less likely to report poor asthma control. This is another classic study, and if you've ever gone to a lecture on air pollution, you're gonna see this study. It's from 2001, but it's another one of those studies that really speaks to compelling evidence for causation of air pollution. So in 1996 Summer Olympics, Atlanta changed up their transportation routes. And what you can see from over here on ozone is that before the Olympics, ozone's high. During the Olympics, when they made transportation changes, it goes down low. And then afterwards, it goes back up again. And what they found was that this decrease was associated with about 42% reduction in pediatric asthma attacks. And that translated into, as air pollution goes up, right, more Medicaid claims. So again, I'm just sort of putting in that plug here of, like, when we talk about healthcare costs, is there a role for us talking about air pollution mitigation? Now, this is a topic that deserves its own symposium, and I am not going to be able to do that. But I could not talk about air pollution without talking about the fact that in the United States, air pollution exposure is not equitably distributed. Outdoor air pollution is increased in minoritized and low-income communities, and I'm sure everybody in the room has heard about redlining. Current day redline census tracts have increased air pollution exposure. In the United States, there is a higher percentage of Black, Hispanic, foreign-born, and persons in poverty who live within 150 meters of a major highway. And there was a study from a couple years ago that looked at air pollution a different way and said, okay, well, what's kind of the ratio for how much groups produce to how much they're actually exposed to? And what they found was that Black and Hispanic persons are exposed to increased PM 2.5 compared to production, which is termed a pollution burden. And the inverse was found for white persons, termed a pollution advantage. This is a landmark study from a couple years ago that looked at rates of asthma emergency department visits in current day locations that had been previously redlined. And what you can see from the figure on the right is those census tracts, so D, that had been redlined, had higher asthma rates. And when you look at pollution exposure in those tracts from A, B, C, D, you can see that there are increased particle pollution, increased diesel exhaust, and increased percentage of poverty. So to me, this says that historical institutional racism contributes to present day environmental and health inequities, and that the policy to end this racist practice, which occurred, I think over 5 decades ago, did not solve, it didn't fix it. So we're going to need specific anti-racist and exclusionary policies to fix this. I wanted to put this slide in just because when we talk about race, I want to be sure that everybody is aware that it is not a biological construct. There's no such thing as biological race. It is purely a social construct. And childhood asthma is very much a health inequity that overburdens Black and Puerto Rican children in the United States. And we know even from data here within children's that Black children have a higher prevalence of ED asthma visits compared to white children. So this group from Cincinnati looked at, okay, so let's see the association between race and ED utilization. And what they found was when they adjusted for these other factors for insurance, so this is Medicaid versus commercial, area level deprivation, PM 2.5, and outdoor mold, this mediated 55% the effect of race on ED visits. So it tells you, again, it's not race, it's all these other factors, including PM 2.5, which is inequitably distributed in the United States. So I'm going to make a very abrupt transition here to talk about the air quality index, but bear with me. So the air quality index is a short-term air pollution behavioral intervention. It's not long-term. We don't use the AQI to think about our long-term exposure risk, just short-term. And this is going to make sense, hopefully, in a couple slides, but I'm going to start off with the NAAQS, which are the National Ambient Air Quality Standards. So the EPA, under the Clean Air Act of 1970, is going to regulate these 6 criteria pollutants: ozone, nitrogen dioxide, particle pollution, ozone, sulfur dioxide, and lead. And they set a primary standard, which is designed to protect human health, and a secondary standard. The secondary standard has sometimes been called the environmental, but it's not quite as flowery as that. It's really to protect human interest and public welfare. So these are the secondary standards are going to protect things like crops, agriculture, buildings. And I want to point out, because invariably, whenever I talk about air pollution, somebody brings up, well, this is really costly for companies. So what you see on this picture is basically the Clean Air Act from 1970 over to present day, so 5 decades. And what you can see is that we've seen marked reduction in those criteria pollutants over time, while at the same time increasing the population, increasing energy consumption, having drastically increased vehicle miles traveled, while also increasing our gross domestic product. So clearly we have decades of experience that shows a healthy, thriving economy is completely compatible with clean air. These aren't mutually exclusive. This is an extraordinarily busy slide. I'm going to walk you through it. We're not going through all of it. All that I want you to know is that bottom right corner, that the final rule of who sets the NAAQ is the EPA administrator. And the EPA administrator is a political appointee, appointed by the president. So if air pollution is something that is important to you, I very rarely hear in presidential debates talking about air pollution, but who you vote for does matter with regards to air pollution. I just point out that within this process, there's something called CASAC, the CASAC, which is the Clean Air Scientific Advisory Committee. This is usually a group of scientists or persons with expertise in air pollution that review documents, review things like the science assessment. And there's multiple points along this pathway for people to provide public comment and to provide thoughts. Our current NAAQs for PM 2.5 and ozone, the current PM 2.5 NAAQ for the annual standard is set at 12 micrograms per meter cubed, but it's not what you think. It's not just an average of 12. It's the annual mean averaged over 3 years. The 24-hour standard is set at 35 microgram per meter cubed, and this is the 98th percentile averaged over 3 years. And for ozone, this is 70 parts per billion. And this is of the annual 4th highest max 8-hour concentration averaged over 3 years. I do not have the time to spend trying to convince everyone of mine and the American Thoracic Society stance that these standards or these NAAQs are not protective for human health. But I will direct you, if you are interested, I recently published a review article with Dr. Baums about a need for a more protective ozone standard where I make the case. And then also the American Thoracic Society puts out a health of the air, and I'm super excited. I think within the next couple of weeks, we're going to see the most up-to-date one, where you can actually see the benefits of if we were to adopt an ATS standard of 8 for the PM 2.5 annual, 25 for the 24-hour, and 60 for ozone. I appreciate this is not a study on kids, but bear with me because I think this is one of the most beautiful scientific manuscripts with regards for policy implication. So this was just recently published, looking at the effects of lowering the annual PM 2.5 standard in the Medicare populations. This person 65 years or older. This study represents over 73 million persons. And what they did find, which I've already mentioned, is that white persons are exposed to less PM 2.5 compared to Black persons. And what you can see on the figure on the right is that as you decrease the annual standard of PM 2.5 from 12 to 11, 10, 9, 8, you can see reductions in hazard ratio for death. So lowering this is good. And what I also point out is, again, for most of these pollutants, we do not have a threshold at which harm does not occur. So I don't know what to tell you how low we can go with PM 2.5 and not have health effects. Same thing with ozone. When they look, though, at groups to say, well, who benefits from lowering the standard, they looked at white high-income persons, white low-income persons, Black high-income persons, and Black low-income persons. And what they found was that lowering the standard from 12 to 1 or 12 to 10 or 12 to 9 or 12 to 8 had more benefit for Black persons and low-income white persons. So this is a health equity issue. Now I'm getting to why I'm talking about the NACs for the AQI. So what the EPA does for these 5 criteria pollutants is they take the pollution concentrations it monitors. They're going to convert it into something easy, because if I tell you micrograms per meter cubed, it doesn't mean anything. Telling you ozone parts per billion really doesn't mean much. But if I tell you the air is green, it's okay, that's helpful. So they convert that to this color-coded categories. And essentially what the AQI is it's the highest pollutant of any of these criteria pollutants of any of the monitors in this region for the past 24 hours. So really the AQI is something that you know in retrospect. This is how it relates to the NACs. So I told you that the ozone NAC was set at 70 parts per billion, and that's the cutoff for this unhealthy for sensitive groups. The EPA advises most persons to actually start making changes right here. So it's usually in the orange range that persons like children, older persons, pregnant persons, persons with lung and cardiovascular disease are advised to take intervention. For PM 2.5, the good range is set at the annual standard of 12, and the moderate standard is set at 35, that annual standard. So what the AQI is designed to do is, when you think about the poor air quality event that happened this summer with the wildfires from Canada, right? You have a poor air quality event. This is going to increase everybody's inhalational exposure. And the more air pollution, this is back to pollution 101, the higher the concentration, the higher the dose, right? And that dose can lead to adverse health outcomes. But if we have a way of figuring out, like, hey, the air is getting worse, the AQI, then we can be aware of it. And being aware of this poor air can lead to reduction behaviors. Back to air pollution 101, right? You don't go outside, you avoid it, you reduce how long you're in it, or you reduce what your ventilation rates are doing while you're in it. Those reduction behaviors then should lead to decreased inhalational exposure, which leads to decreased adverse health outcomes. I'm going to quickly fly through this, but again, the moderate group here says for people unusually sensitive. And as a clinician, I don't know who that is. I don't know if I'm unusually sensitive. I don't know if my patients are unusually sensitive. And I know the NACs, and I believe that they are not sufficiently protective. So I wonder how many people are actually unusually sensitive. This is what on Air Now on the app, if you download it from the EPA, looks like. It'll tell you the AQI. So this is for the Pittsburgh reporting area, shows that it's moderate. If you click on it, you get the next little picture that shows PM 2.5 is 81, Ozone was 77. So of course the AQI is going to be 81. This was on another day when it was in the orange range, which you can see the behavioral recommendations that are listed. It says people with heart or lung disease, older adults, children, teens. To again, this goes back to the, what do you do to reduce your dose? You choose a less strenuous activity, shorten the amount of time outdoors. I just want to make this quick note about where our patients may be getting the AQI. Not all AQIs are equal. So the EPA puts out the AQI, right? They're the ones who are regulating it. They're the ones that designed it. And you can get that through AirNow, either AirNow app or airnow.gov. What they do is at times when air pollution is less variable, they have longer averaging times. And when air pollution is more variable, they have shorter averaging times. I have patients that have told me, oh yeah, I look at that on my weather app. On my weather app, I have an iPhone. There's an AQI, and when I click on it to be like, okay, where are they getting this? It says it's from Breezometer. And when I clicked on Breezometer to figure out, well, what is this? They say they use a 1 hour averaging AQI. So this is different from what the EPA puts out. And that there's multiple sources from it, including traffic, government sensors, low-cost sensors, satellite data, and other such. Purple Air is a company where you can get sort of these crowdsourced, you can purchase a PM 2.5 monitor. How it monitors PM 2.5 is by a different method than what the EPA uses, and it provides a 2-minute average for the AQI. IQ Air provides another one. I only say this because I don't know what the health effects of 1 to 2 minutes in this AQI. So I just point out that when people are talking about the AQI, they may be getting it from different sources. Ways that our patients can use the AQI, right? So you can receive alerts and emails when it's forecast to be poor the next day. So you could say like, oh, well, okay, air's going to be bad tomorrow, so I'm not going to go outside. I think another way you could do it is look on AirNow, because it's going to provide that sort of hourly real-time value. So you could look at it before you go outside to decide, like, maybe I'm not going to run 5 miles, maybe I'll just do 1. But I think the other way you could do it is to learn your individual sensitivity. And I point out this is not the way the EPA has designed it, but that is a way you could potentially to say, okay, you know what? I've discovered when it's up at 75, I have symptoms. I can't talk long about this. I just want to point out not all countries have the AQI. Different countries do different things to have an air quality index. Canada does something different. Canada has an air quality health indicator, which is a composite of 3 air pollutants. So what Canada did is they initially had an AQI, realized that their AQI wasn't that predictive of mortality, but this was better predictive of mortality. So it's on a range of 1 to 10 plus. And as part of Canada, they do recommend learning your own individual sensitivities to air pollution. So for an air quality index to reduce harm, and I'm talking about any air quality index, the index derived from pollutant concentrations should be associated with health outcomes it seeks to prevent, right? So if AQI isn't associated with childhood asthma exacerbations, then how is telling our patients to follow it going to help them if it doesn't really track with asthma exacerbations? It must be easily understood and widely accessible. If I have to read something, it's over with. It's not going to happen. Persons have to be aware of the index, of how and when to use it and how to respond. People have to be able and willing to implement the response. So back when we had bad air quality here in Pittsburgh in June, the answer wasn't like, oh, well, hey, just go to Aruba. The air quality is better, because that's not feasible, although fun. And the response should result in decreased exposure and therefore decreased adverse health outcomes. And surprisingly, for a lot of these, very little work has been done regarding the US AQI. So this was a study out of California looking at the association with adult respiratory emergency department visits. And I've put this little red circle on what represents the AQI. And in these 3 different regions, what you can see is that sometimes the AQI was associated with adult respiratory visits, but not all places and not all times. And it really seemed to be when it tracked with PM 2.5 is when it performed better. So me and my co-authors looked at this here using children's data a couple years ago, looking at, okay, well, what's the association of the AQI with asthma emergency department visits? And what we found was that looking at the AQI as a continuous variable, so just going up 10, it was associated with ED visits on lag days 2 and 3. Same thing when we looked at it as a categorical, so this is going from good to moderate to unhealthy. On lag day 2, it was also associated with asthma exacerbations. So this was primarily driven by PM 2.5 and not associated with ozone. That doesn't mean that ozone doesn't cause asthma attacks. What it says is using the AQI isn't associated. It may not be predictive. Maybe we need more monitors. Maybe we need something else to protect against the harms of ozone. And I just want to point out that within our region, the majority of days were in the moderate range. So what that tells me is at least some of my patients, and I don't know who they are going to have symptoms associated with air pollution within that yellow category. This was a study that came out earlier this year that looked at kind of the same thing. And they looked at asthma exacerbations. They looked at the asthma attacks in their cohort that needed steroids, those that didn't need steroids. And then they also had nasal samples to say, okay, well, when was a virus associated with it and when a virus wasn't? And for the group of kids that had asthma attacks that needed steroids but didn't have a viral trigger, they found an association with moderate ranged AQI. And about 30% of those steroid asthma attacks were associated with this. So from their cohort, that says at least 30 to maybe 48% of kids with asthma might be in this moderate range. So we looked at a very small pilot study, but just to say, okay, hey, if we put the AQI on the back of Childhood Asthma Action Plan, what happens with regards to asthma attacks, asthma control, and pediatric quality of life? And we recruited we recruited during the summer of 2020. And so everybody exited the study in the wintertime in January and March 2021. We didn't find, and again, this is a pilot, it's a small study. We didn't find any association with asthma exacerbations or any impact on asthma attacks, but we did find this. We found that in those that received the intervention, they had increased asthma control scores. The higher your score is, the better your asthma. But I also looked at activity. And so this question was just looking at 10 minutes in the last week of vigorous or moderate activity. All right, so a low bar. And what we found was, as you would expect in summertime, most of the kids in either group, 70–90%, were active outdoors. In the exit, that number is markedly less. Okay, that checks. This is Pittsburgh. It was wintertime. And when we looked at odds ratios, which is what's showing in that within group, yeah, this was statistically significantly different. So over time, activity reduced. But between the group differences, this was also significant, which shows that for those that had the AQI in the back of the asthma action plan, they did have less or more reduction in activity compared to those without. And you might say, well, isn't that what you wanted, right? The AQI, Air Pollution 101, reduce exposure. And I would say, most of the days were in the moderate. There were only 8 days that were orange at levels at which the EPA would advise. So I think, to me, what this shows is, one, we need more research. And two, if we're going to use the AQI as a tool to learn your own personal susceptibilities, you really need to track physical activity closely, because physical activity is so good for a multitude of reasons for children and adults. So I'm going to finish up by this figure showing, okay, well, what is individual action versus policy action? And I'm talking about the AQI, which is a personal behavioral intervention, right? When we look at what is the benefit for the most patients, it's policy actions. An individual action is going to have the highest burden on an individual person and not the most benefit for most people. So really, at no point in time should any air quality personal intervention come at the expense of policy. Policy is going to be the best and most equitable. My final thoughts about the AQI, it's hard to study, but I think the AQI is enormously helpful, and I'm so grateful the EPA gives it to us. I think it has probably saved countless lives and decreased a lot of morbidity. But I do think we need more research to better understand the benefits and limitations of a single pollutant AQI. What is the best usage? What are the average intervals we should be looking at, and how to use this clinically? And my guess is that this is going to be different depending on regional air pollution differences. So what you're looking at, the figure on the left-hand side, is Allegheny County, and you can see that we all pretty much live our life in the yellow. Half of the years are in the yellow, with very few of these high spikes, compared to Portland, which is over on the right-hand side, which they live most of their life in the green, except for these occasional really large spikes. My guess is this is coming from wildfires, where they have bad air pollution days. And you can think about, again, if you're trying to tell someone with asthma you might be susceptible in this moderate range, how much they might have to limit their activity is going to look different in Portland than it's going to look like here in Pittsburgh. And I promised you this is where I was going to end up, and this is where I got to. We all should be aiming for clean air because it's good for us, and we should be avoiding and strongly advocating against dirty air because it's bad. And with that, I'm happy to take any questions.